this case is just a classic colorectal cancer case, which shows some of the good things that are going on and some of the challenges for the field. First of all, we have options. We have 13 different drugs, if you start to include the immunotherapy drugs for MSI-high patients or deficient mismatch repair patients. So we have a lot of different agents and a lot of different combinations. And if you think about, 20 years ago when patients lived 3 to 6 months with this disease, and now patients are living more than 36 months if you're left-sided, for instance, in RAS wild type. So there's a lot of reason to be somewhat comforted by the fact that we've quintupled survival from before all these agents were used. On the other hand, this points to a lot of deficiencies in the field. So first of all, which cytotoxic backbone should we use? We don't have any predictive tests for that. There's some arguments about ERCC1 and topoisomerase, et cetera, but none of those have really panned out in large trials. So the choice of a cytotoxic backbone is still completely empirical, which is surprising in the 21st century. Second, we don't know what targeted therapy to use, especially for VEGFR. So when you use bevacizumab, zivafliprcept, ramucirumab, or even regorafenib to a point, it also has anti-angiogenesis properties. We really need biomarkers to predict who's going to benefit from those, and we don't have them. So there are no tests you can send to say, should I give this patient this expensive therapy? Granted, the side effects usually aren't too bad, but should I be giving that? It's largely empirical. And the third is that this patient was microsatellite stable, so they do not benefit, as far as we can tell so far. There's some trials going on, but they don't benefit from immunotherapy. And that's been a very frustrating thing across the field. Why doesn't colorectal cancer respond to immunotherapy the same way that other diseases do? We know that deficient mismatch repaired microsatellite high patients, they benefit, but they're only 4 to 10%, depending on what you're looking at. So that's been a frustration as well. For over 90% of the patients, we don't have effective immunotherapy. And so it's been a great deal of frustration in terms of moving the field forward. So on the good side, 13 drugs, some of them biomarker driven, quintupling of survival. On the bad side, still no good immunotherapy options for microsatellite stable patients, no predictive tests for cytotoxic therapies, no predictive tests for angiogenesis inhibitors. And this case, I think, wraps up many of those themes all in one.